All right. Well, hi, everyone. Thanks for coming. My name is Adam Leventhal, and I'm director of the USC Institute for Addiction Science. And you are here for our Distinguished Speaker Series. And we are very, very glad to have Andy Subica as our distinguished speaker. Before I get started, for those of you who don't know about us, the Institute for Addiction Science is a university-wide collaborative unit at USC, where we try to bring folks together from various types of disciplines. We have 77 members across 7 schools at USC, and we really focus on cell-to-society research, education, and community engagement to reduce addiction. I want to thank our sponsors, the School of Social Work, the School of Pharmacy, and the School of Medicine at USC, the Norris Comprehensive Cancer Center, and the Department of Population and Public Health Sciences. Now with that, I'm very, very excited to introduce Andy. One more housekeeping thing is that if you have questions, you can put them in the chat. There's a Q&A function. And also at the end of Dr. Subica's talk, there will also be an opportunity. If you want to ask a live question, you can raise your hand. So either or is good. So now let me introduce Dr. Subica. So Andy is an associate professor of social medicine, population and public health at the University of California, Riverside School of Medicine. His research examines and addresses substance use, mental health, and physical health disparities in vulnerable populations. He uses mixed quantitative, qualitative, and community engaged research methods. He's particularly focused on developing evidence-based interventions to address the behavioral and also the structural causes of health disparities in underserved communities. He's interested in effects such as cultural trauma, social disadvantage, and stigma and its role in population health. He's gotten quite a bit of funding from a number of different agencies, including PI from grants from the National Institute on Drug Abuse, the National Institute on Alcohol and Alcoholism, National Institute on Mental Health, the CDC, and other entities. And then prior to joining UCR, he served as a mental health scholar actually here at University of Southern California through the Clinical and Translational Science Institute. And he is a psychologist by training and grew up in Hawaii and now has been here in Southern California. And we're really, really excited to have him talking about his really innovative and important research program, which really addresses the needs across Southern California. So Dr. Andy Subica.
Well, thank you so much, Dr. Leventhal, for that introduction. That was really great. I'm always a little bit embarrassed being from Hawaii to hear people talk about me. So, Zoom is not always the ideal method for delivering this, but I appreciate everyone who's logged on today. I'm going to try and keep this fairly moving pretty quickly. So I guess I'll just kind of dive right into it. So the talk today is called Utilizing Community-Engaged Methodologies to Target Substance Use in Vulnerable Populations. This is a talk to the USC Institute of Addiction Sciences. It's February 23rd, 2022. Before I talk about the actual topic, I will say as a health disparities researcher, I have a lot of different areas of research that I'm focusing on. So it was a little bit difficult to actually narrow it down to one topic. I do like working on things like cultural trauma, stigma, public mental health. But when I really thought what would be most important for the Institute of Addiction Sciences, I landed on this, the concept of community engaged research. So in 2006, the National Institute of Health began to emphasize something called translational research, which simply put is translating scientific discoveries into practical discoveries to improve health. And part of the reason that the NIH began to emphasize translational research was earlier in the 2000s, there had been a 10 to 25 year gap identified between research and clinical practice. What this gap really means is that from the time, let's say there's a new treatment that's developed, it goes through randomized controlled trials, it's ready for prime time, it can still take anywhere from 10 to 25 years for me, for people on this call, for your family members, to actually be able to go to your local hospital or clinic and receive this treatment. And then for vulnerable communities, disadvantaged communities, which I work with, they may never have access to these new treatments. So one of the reasons this translational gap was thought to occur was because of weak community research communication, which left community concerns and interests out of the research agenda. Now, community engaged research is an attempt to kind of bridge that gap. So according to the CDC, community engaged research is this process of working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar situations to address issues affecting the well-being of those people. Now, the key thing here is when you conceptualize a community, it can't be a community that is geographically connected. So for instance, I'll talk later about South LA, which is a community that is defined by a specific geography. But I do a lot of work, for instance, with Pacific Islanders, both in the US and the Pacific. So they're not bound by geography, but they still, in my mind, are considered a community because they share a special interest in this case. So community engaged research is a collaborative research approach between academic and community partners. The goal is to address issues of local community concern and need. One thing I really like about community engaged research is it doesn't address health and health disparities from a deficit standpoint entirely, but it recognizes and leverages community strengths and resources. And then it builds community capacity to do research, or more importantly, I think, affect change. Now, most people on this call were probably familiar with community engaged research, but it's really good to get a grounding because community engaged research is very good for addressing this issue, the issue of health disparities, which I know everyone on this call is well aware of. Just a quick definition then, don't want to spend too much time on this. Health disparities are group differences in health status that result from social, economic, or environmental disadvantage. And the concept of a disadvantage driving health disparities is really important because health disparities then are caused by things like lack of access to clean air, unclean, polluted lands and seas. This is a picture of Huntington Beach. Lack of access to clean water, for instance, can drive health disparities, as well as social factors such as poverty or lack of access to housing. I think people here from USC are pretty well aware this is Skid Row. And the problem with all these social and structural factors, these inequities, is that they impact health because they make it in part difficult to get access to affordable, adequate, quality healthcare, both mental health and physical health. So as a kind of health disparities researcher, one of the things I often think about is how can I actually conduct research to target, to study, to address health disparities when it's driven by not just behavioral factors, but also structural factors, social inequities. And one way to do it that I'm going to talk about now is applying community engaged research to tailor existing health research and interventions to actually target health disparities in vulnerable communities. And for my own work, as a demonstration, let me talk about a method that I helped develop called Citizen Panels for Health Equity. Now, Citizen Panels is not something I created. It has a rich history in deliberative democracy, what's known as deliberative methods, which are pretty well known in the public policy, the poli-sci world, but has not really been applied to public health. So what are Citizen Panels for Health Equity? It's a deliberative method that engages affected residents and stakeholders in informed deliberation and decision-making to adapt existing research and interventions for greater relevance and impact on vulnerable communities. So in 2020, me and my colleague, Dr. Brown at UCR, we published this Citizen Panels for Health Equity in American Journal of Public Health. And what we basically described in that paper was the purpose of community engaged research and the procedures. So basically Citizen Panels, and the purpose of Citizen Panels is to capitalize on participants' situated knowledge of their conditions, their practices, their needs, their health disparities, which a academic partner such as myself, who's not, let's say, from South LA or not from Samoan community in Carson, California, wouldn't really know and recognize unless I actually worked with people on the ground living in these communities. So what differentiates citizen panels from other qualitative approaches such as interviews or focus groups is in a citizen panels, we typically convene about 15 to 30 community members into a large space or a room. And the goal of the citizen panels is to collect rich, in-depth data, much like interviews and focus groups, but ultimately to drive discussion so that we can reach a decision on a specific health disparity topic. And the way we first begin this deliberation is I spend, or the facilitator will spend the first 5 to 10 minutes presenting about the specific topic we're trying to think about or the different subtopics. Basically, we want to present options to the community so that they can engage in informed deliberation and discussion. After this kind of early pre-setting the table for everybody around the topic, we then split out into breakout groups where each breakout group will discuss presented options to reach a group consensus. And we typically like to stratify these breakout groups much like you would a focus group. So you may have young adults, you may have older adults in another breakout group, Pacific Islanders or Latinx individuals who have high risk for alcohol use disorders in one group, and then people who are at low risk in another group, so that we can get a diverse array of opinions and perspectives as well as decisions. After the breakout groups make their own small group consensus, we reconvene, every group shares their decisions and the reasoning behind it, and then we vote to reach a panel-wide consensus. So that's a little bit complicated, probably. So let me just talk about how this has been used and how it can be applied. So one way that panels can be applied is in shaping a disparities research agenda. And for this, I'll use the example of adults aging with HIV in Coachella Valley. So through a core engagement award, me and my colleague, Dr. Brown, we basically worked, and he does a lot of work with this community in Palm Springs specifically, because Palm Springs has the highest prevalence of gay men over 50 who are living with HIV in the US. They're about 12 times the national average. The interesting thing about this group and this population, this community, is that HIV became a pandemic in the 1980s. It's only really been studied and known for about 40 years. So these individuals are among the first cohorts to actually age with HIV. So we don't really understand yet exactly how HIV and aging interact. What we do know is that the interaction does increase risk for medical comorbidities. For instance, up to the point right now, 50% of all deaths of people living with HIV are actually caused by age-related chronic conditions, heart disease, diabetes, stroke, rather than the virus or the AIDS disease itself. So what we ended up doing through this core engagement award was they had created a coalition that they called HARP-PS. And for years, HARP-PS had been approached by very well-recognized researchers, places like UCLA, UCSD, USC in New York, in Florida, with a number of research studies. But the capacity of this group wasn't that great, and they weren't going to be able to support a number of these different studies at the same time. So the goal was to basically use these panels to get the community feedback and determine which research studies should we pursue, which would be most impactful and important for the community. So we had 3 citizen panel sessions. The first was chronic inflammation. The second were studies around cognitive function. And the third were studies around substance use and depression. And I'll just talk about the ones that the community prioritized. So based on our citizen panels, we came out of this knowing that these were the 3 studies that the community felt we should study around substance use. The first was medicinal cannabis. The second was psilocybin for depression and isolation. And the third was methamphetamine use, both positive and negative uses of methamphetamines in older adults aging with HIV. So that's a quick example of how we were able to use citizen panels to align a research agenda that really hit on the main community priorities and interests. But at heart, I'm an interventions researcher. I develop behavioral interventions and community level interventions. So this is what I'm gonna spend kind of a big chunk of time talking about. And I'm gonna use the example of Native Hawaiians and Pacific Islanders. So Native Hawaiian Pacific Islanders are an indigenous colonized racial group. They're actually the smallest federally designated racial group in the US. There are currently about 1.5 million Pacific Islanders who live in the US. and over 10 million who live throughout the Pacific. But mirroring Indigenous American Indians and Alaskan Natives, who we have conducted much more research and studies on, Pacific Islanders have also endured extensive historical trauma and loss at the hands of the US. Most people have learned in history, for instance, about the US military-backed overthrow of the Hawaiian monarchy in the 1890s. But less well known are the many other historical traumas that have been perpetuated on Pacific Islander peoples by the US. For instance, after World War II, the US military detonated the equivalent of 7,200 Hiroshima-sized nuclear weapons in the Marshall Islands. The challenge, though, was that they failed to adequately evacuate a number of the Marshallese people. The ensuing radioactive fallout, unfortunately, then has contaminated generations of Marshallese lands, food sources, and the Marshallese people, to the degree that now Marshallese individuals here living in the US, in places like Arkansas, Iowa, and Hawaii, are among the most health poor in the entire nation. And it's in this context that they approached me and actually asked me to try and do a study to address alcohol use in their communities. And that's what I'm going to talk about here. So this was an NIAAA R21 we recently completed. And this was entitled Developing a Prevention Model of Alcohol Use Disorder Among Pacific Islander Young Adults. Now, the purpose of the citizen panels here was to actually collect Pacific Islander community member feedback so we could create the first culturally grounded alcohol prevention intervention for Pacific Islander communities. And the reason that we wanted to pursue this was the very little data that had existed on Pacific Islander alcohol use here in the US. There's more foreign data than definitely US data. A study I did with a colleague, Dr. Litsi Wu at Duke, that looked at 25 years of CDC youth risk behavior survey data, found that NHPI youth had the highest prevalence of preteen alcohol use and heavy episodic drinking of every racial ethnic group over that 25-year span. In a subsequent NIMH R21 survey study we did, 22% of Pacific Islander adults screened positive for alcohol use disorder in our community sample. That's 4 times the national average for alcohol use disorder. So that gave us a lot of confidence that this was something we should explore. Then during COVID-19, now in new surveys that we've done, about 27% of Pacific Islander adults have screened positive for alcohol use disorder. And then in other studies we've done, up to about half of Pacific Islander young adults, so 18 to 30, our target population for this R21, have screened positive for alcohol use disorder. And then this is the group that I'm working with in Arkansas, the Marshallese community, Arkansas Coalition of Marshallese. And so understand that every one of these projects I'll be talking about today are really led and conducted by the community themselves. And so we decided to conduct 2 citizen panels in this study. The first one was in Arkansas with the Marshallese community. The other was in LA with Samoan community. And we had 3 different goals. The first was to ask the community to rank the top 3 alcohol use disorder risk factors for Pacific Islander young adults. The reason we want to focus on this is in order to prevent alcohol and substance use disorders, it is believed that you should identify what the main risk factors are driving those alcohol and substance use disorders. So we really wanted to isolate which ones were the most important to address. The second question we had was, let's ask the community to decide which evidence-based intervention content should we be using? And then how do we integrate traditional Pacific Islander cultural and healing practices with evidence-based content to actually impact the communities? And then the third was we asked them to help us choose the best intervention delivery formats and then select the setting and recruitment strategies for them. As examples of the different evidence-based alcohol prevention interventions we presented a list, but these are ones that I think people on the call might know. We presented options like alcohol EDU, e-chug, life skills training, text message-based alcohol programs. And this is what a citizen panels looks like. So this is the citizen panels that we conducted in Arkansas with the Marshallese. And we can tell is that I'm standing in the front of the room at the very start. And this is where I'm presenting via PowerPoint the different evidence-based options that I want them to think about and then rank, basically. And then after this, we're going to break out into breakout groups, and then we're going to reconvene and render a decision. So what does this actually look like in practice? So here are our consensus choices. So remember, we gave them a number of options. We asked them to consider, should effective alcohol use disorder prevention intervention, should it be web-based, for instance, like Alcohol EDU? Should it be smartphone app-based? Do they prefer text messages? Should it involve individual counseling? And what they actually came back, both communities almost unanimously decided, to our surprise, was that we should develop our intervention as a weekly group with other Pacific Islander young adults. The other thing that surprised us was they said we need to have parent young adult communication skills training involved in this. In effect, they were saying that they wanted their parents to also be a part of this if possible. And that really surprised us. When we asked them, okay, so what should the content look like? Well, they said personalized normative feedback. We should be using, alcohol researchers here are probably familiar with that. But here's the main thing is they said there are 3 risk factors we needed to address in our intervention. The main first one was drinking to cope with stress, especially from parents, the stress they were experiencing from their parents. The second alcohol use disorder risk factor was peer and family pressure to drink and drink heavily. What one participant said, they're expected to at parties drink till you drop. The third is cultural difficulties in turning to parents for support when they're experiencing distress. And so what was then evident after this session, when we started doing the analysis, was why it became pretty clear why the young adults wanted their parents involved in this communication skills training. Parents were a very strong risk factor across all 3 of these, risks. We're also able to get quite granular in the questions we were asking. So we gave them 10 possible drinking consequences in order to understand which ones should we be highlighting our intervention to deter alcohol use disorders. The first one they said was the big problem was physical fights. The second was driving while intoxicated. And the third was getting into trouble with law and police due to alcohol use. And then they said there are 3 elements we needed to incorporate. Poor parent communication due to intergenerational differences. They highlighted very strongly the importance of including spirituality and religion in our intervention. The overwhelming majority of Pacific Islanders, both in the US and the Pacific, are religious. So this was something that came out very strongly. And the third element was navigating cultural differences between being Pacific Islander and being American. Then for our third session, they basically said we asked them where should we be conducting this? And they said either a private room at a local church or at a rec center, or they said outdoors at a local park or beach would be good. But to our surprise, they also said if neither of these are options, they would be accepting and they would actually use every week a Zoom weekly group intervention. And then finally, we asked how should we recruit young adults? Because it's quite difficult to recruit Pacific Islander community members, especially for an intervention. And they basically said there are 3 ways we should focus: word of mouth at events, social media sent by friends or peers. And this was interesting because we actually asked them to consider if they would be convinced to engage in our intervention if we did Facebook ads or Instagram ads. And they actually basically said, no, it would have to be from someone they knew to actually work. And the last one was word of mouth by family members. So older siblings, cousins, or parents, people they respected and knew. So as you can see, based on just 2 citizen panels in these 2 communities, so 4 hours each approximately, we were able to create a very, very strong conceptual model of what an effective, culturally grounded alcohol use disorder prevention intervention would look like for these communities. And so based on simply just this conceptual model, we're now preparing this for an R01 application, I believe this summer. And I think we have a really good sense of what it should look like so that we can now proceed into R01 just to designing it and then doing the RCT. Now, just to wrap this part out about the substance use and community engaged approach, currently the R21 is closed and we have an ongoing R34 from NIDA. But what you can see that I have here is the fact that citizen panels is one method that you can use within this broader community engaged research field. But ultimately, we had to develop an iterative intervention development model. So we did end up coming up with this modified Delphi approach, which we're now applying in this new grant that we're running. So this is an intervention development grant that's exploring opioid and meth use disorders among Pacific Islanders. The challenge with this was we really don't have almost any data on opioid and methamphetamine use or disorders in this community. So we decided to base our study on these anecdotes that we got, specifically from rural Native Hawaiians in Hawaii and urban Tongans in Salt Lake City, who reported they were at high risk for these disorders. And the goal then was basically to be very simple and identify the scope and the scale of opioid and methamphetamine use in these communities and identify their barriers and facilitators to treatment so that we could create and pilot test the first opioid methamphetamine treatment engagement intervention for Pacific Islander peoples. But this is a little bit of why I want to highlight the challenges of community engaged research, especially around substance use, which is a highly stigmatized and sometimes difficult to capture construct for hard to reach communities. So during COVID, we ended up doing 306 online surveys as part of this NIDA R34, really just to get a sense of what's the scope of use in these communities. And what we found was that for illicit prescription opioid use, we only found about a 5% prevalence. For current methamphetamine use, it was only 1% prevalence. And so this stumped us a little bit because this was suggesting that maybe this isn't quite the issue that we needed it, or I guess it wasn't quite the issue that we had been told and were worried about. So, we were thinking at this point of shifting our grant a little bit to other substances that were emerging. But then what happened in 2021 was, as we were talking with our community partners, especially in Hawaii, we started to see all of this concern and these stories starting to come out about drug overdose deaths spiking in Hawaii related to both methamphetamine and this new issue around fentanyl. As you can see, in 2021, just last year, there were starting to become a lot of concern and a lot of press reports about the issue around fentanyl and opioids. So instead of shifting away from opioids, what we ended up doing was we had more conversations with our community partners to really understand what should we do next. And basically, we thought, let's try and see where the Pacific Islanders who have these disorders might be living. Where might we find them in the community as opposed to in incarceration or in the court system. So we looked at 101 individuals experiencing homelessness, and 94% of our sample ended up being Pacific Islander. And when we looked at illicit prescription opioid use, it was 29%. Current methamphetamine use was at 73%. So this has now sparked a lot of these, we're writing technical reports. We actually are discussing this now with the superintendents because there have been a rash of fentanyl-related overdose deaths in Hawaii that have the schools very concerned. So we're deep in the middle of this right now. But this is an example basically of how we've had to pivot a lot when we're trying to do this type of research. I just want to highlight that it's partners like Hawaii State Rural Health Association that make this possible. And especially this gentleman, Mr. Sammy Sampaga, he's a well-known activist in Hawaii. We actually trained him to do surveys and he was able to do at this point 160 surveys of people experiencing homelessness in the Big Island. And what's amazing about it is that he has been going to beaches, parks, homeless encampments, and even going into the rainforest itself, where a lot of these encampments have moved in order to be able to collect this data for us. So for instance, Sammy is kind of the pivot point for being able to do this NIDA R34 at this moment. I guess I'll just basically skip this. We're also having a NCI R01 under review to develop a multi-level smoking cessation intervention for Pacific Islander communities. But one of the reasons I really just wanted to highlight this is I'm working with someone from USC, Dr. Sheila Murphy in the Annenberg School of Journalism, who's a health communication expert. Because what has ultimately happened is I'm a clinical psychologist, definitely not someone skilled in health communication. But the more work I've done with underserved communities, Latinx, African American, Native Hawaiian Pacific Islander, I'm realizing that one of the most important things to do is health communication, outreach, and engagement rather than behavioral interventions, which can come later down the chain of research. So let me see, I want to make sure we're on time. Okay. So let me check. I know we have a chat. Okay, no questions. All right, so I guess I'm just going to wrap up by talking about a whole different field of work with a different team. And I like this one because it demonstrates how diverse community engaged research methods can be around substance use and health disparities. So this is an example of a study that emerged from the community, went up to kind of the research level, the academic level, and then went back to the community. So I very much like this one. And also I'm wanting to talk about it because it's relevant, I believe, to the USC community. So the purpose of this study I'm going to talk about was the fact that the big issue facing a lot of low-income communities of color that I work with is that they bear a disproportionate burden of substance use, crime, and violence. And for this work, this was partnership with Dr. Cheryl Grills at Loyola Marymount University, and one of my colleagues, some of y'all are now familiar with Dr. Jason Douglas at Chapman University, and then this wonderful community organization in South Los Angeles called the Community Coalition for Substance Use Prevention, also known as COCO, which has been a longtime partner of Dr. Grills for over 25 years. So some of you on the call are very familiar with South Los Angeles. Some of you may not be though. So South Los Angeles is a large metro area in LA County that has about 800,000 people as of 2020. South LA has LA County's largest concentration of African Americans, second largest concentration of Latinx individuals, and the poverty rate in South LA is about twice that of the national average. But when we speak to community residents in South LA, COCO, we do surveys, when we try to engage them around mental health, substance use, or health, the main concern typically becomes about crime and violence. And so South LA's homicide rate among individuals between 15 to 34 years is actually about 4 times greater than the national homicide rate. And so when I started pursuing this study in 2015, the year before in 2014, LA Times had published this article about LA County's Death Alley in South LA, which is a 2-mile stretch on Vermont Avenue below USC, where 61 people had been killed over the prior 7 years. So this was naturally top of everyone's minds while we're conducting this health research with COCO and South LA residents. So the project I'm going to talk about was actually a $3 million CDC REACH grant that COCO got with Dr. Grills at LMU and the rest of our team. And as the first salvo in this larger REACH grant, which was targeted actually towards physical activity and healthcare, we decided to do what's called community participatory mapping sessions. And this is something my colleague, Dr. Douglas, published back in 2020 that he says is useful for diagnosing upstream determinants of health and prescribing downstream policy-based interventions. And so the purpose of community mapping in this REACH grant was to capture residents' perceptions on the nuisance properties that were shaping community crime. And so the mapping sessions were conducted by COCO, and they involved 40 South LA stakeholders, adult residents, youth residents, public health and park officials, as well as gang interventionists. And the purpose was to chart where were the nuisance properties that were preventing South LA residents, especially their children, from being able to use local parks. Because when residents don't feel safe in certain areas, they're not going to let their children get outside for physical activity. They're not going to be using local parks. If there's a lot of people using substances or drugs at these locations. So we really just want to identify where were these problem properties and areas. And this is what mapping looks like. So it looks like a focus group, but instead of asking open-ended questions, what's really neat about it is you present them with a map of their neighborhood, and then you ask them to draw on it, point out the exact locations that they're concerned in the community. And then we analyze that. And what we found from these mapping sessions was that participants reported elevated levels of criminal activity around 3 types of legal drug outlets. And this is where the substance use comes in. Oh, there's a chat. Oh, okay. Thank you, Steve. And the 3 drug outlets were off-sale alcohol outlets. So these are what we refer to as liquor stores or corner stores. The participants were actually also quite concerned about medical marijuana dispensaries. And the third one was the one that I found really interesting, was tobacco shops. We more know these as smoke shops, sometimes here in Southern California. And it was that part, the smoke shops, that really got me. In fact, it was a comment that a gang interventionist made. He said, smoke shops are bad. They're the new liquor stores. That's where the gangs hang out now. And so for some reason, that comment just stuck with me for weeks afterwards. And so I started to look in the literature around smoke shops and tobacco shops. And at the time, I found 0 studies conducted in the US around tobacco shops, especially linked to crime and violence. But I did find 2 or 3 studies in Ireland where they're called head shops, and they were subsequently banned. So basically, we started thinking, let's look at these nuisance properties, since the community has told us these are the legal drug outlets that we need to be focusing on. So what is a nuisance property? Well, evidence suggests that in communities, substance use and crime, they're not equally distributed throughout the community. They're actually attracted, they are concentrated in these specific locations that have specific traits. An interesting one when it comes to crime is payday lenders. People don't often think about it. I didn't until I read this study, but people go in at the end of the month, they cash their checks, and they leave these lenders with a lot of this cash. So in the criminology literature, this makes them what's called an attractive target for a motivated offender. So this is one possible nuisance property. But the idea of crime hotspots is not new. What I really needed to understand was, is there a theory for why low-income communities of color are attracting, these nuisance properties with high levels of substance use and crime? And what I ended up finding was a concept called social disorganization theory, which is the inability of a community to realize the common values of its residents and to maintain effective social controls to resolve problems. What does this mean? Well, in socially disorganized communities, you see a breakdown in residents' informal ties with each other, as well as their formal relationships with authorities. And so as a result, in these disorganized communities, research has suggested that substance use and crime will increase because the informal ties, these friendship networks, recreational leagues, and activities that are essential for creating informal social controls, they start to break down. And informal social controls are very important for preventing substance use and crime, because these controls are the ones that actually include self-policing these issues through surveillance, supervising youth, or reporting suspicious activity to authorities. A well-known example of this would be a neighborhood watch program. An example I typically use when I talk about this concept is, I always like to use Beverly Hills as an example. So if you were a shop owner or resident in Beverly Hills and you saw a number of young adults who were drinking, smoking, and loitering around the specific area, you, the shopkeeper, might be likely to either say something to them or to call the police. This, we found, hasn't necessarily been the case in, for instance, low-income communities of color, where where these people congregate or will be drinking. Residents may be less likely, if social disorganization is high, to actually enact both informal and formal controls. And that leads to kind of these escalations in substance use and crime. But we had this very fundamental hypothesis that are crime and violence associated with tobacco shops, medical marijuana dispensaries, and liquor stores. So at the time, I really had no research team. So I ended up basically finding every tobacco shop, dispensary, and liquor store in the 8 South LA zip codes. And this is what these property types look like. So this is a liquor store in South LA. You can see this one's a corner store. You can see why it's called a corner store. But for tobacco shops, this one actually also looks like a liquor store, but they're very diverse in the way that they look. This is another tobacco shop, smoke shop in South LA. And then at the time, this was a medical marijuana dispensary. And they look very different also, as opposed to liquor stores, corner stores. And then I just have this picture here to show that even in 2015, when I was first starting to map this stuff, on weedmaps.com, you can see that there's already a very high concentration of medical marijuana dispensaries. And this is not a very big area portion of South LA. And I also will say there's a fourth property type that I looked at, which I looked at as a control property, which are grocery convenience stores, because grocery convenience stores are also licensed to sell alcohol and tobacco, but are not considered legal drug outlets. So Dr. Douglas compiled all the property violent crimes in 2014. Property crimes were all felonies: arson, motor vehicle theft, burglary, and violent crimes were things like homicide, aggravated assault, rape, and robbery. And what did we find from this study? There were over 15,000 property crimes, 14,000 violent crimes in 2014. Then we conducted what's known as buffer analyses, which is basically you take a smoke shop and you go out to 100 feet, 200 feet, and 500 feet in these 100-foot, 200, 500-foot radiuses. And all the crimes that occur in this circle are your 100-foot, 200-foot, and 500-foot buffers. So what we found was that 100 and 200 feet of our 3 legal drug outlets, they had higher mean rates of property violent and total crime versus grocery convenience stores. And what this looks like is here, you notice just at 100 feet of every, so 100-foot buffer throughout the entire South LA community, you got about 0.6 property crimes per 100-foot buffer. This jumped up to about 2 property crimes around tobacco shops and our other legal drug outlets, and that dropped to 0.22 around our control grocery convenience stores. And you'll see a similar effect for the violent crimes, 0.5 for 100 feet, and then it jumps to between 2.5 to 1.6 around our drug outlets. And then around convenience stores, there were 0.09 violent crimes in 2014. Okay. So just to wrap this up, at 100 feet, tobacco shops and liquor stores had higher property and violent crime than grocery convenience stores, which were our control. And then at 200 feet, we found the same pattern. So what did this demonstrate to us? This demonstrated that crime is localized around tobacco shops and liquor stores, but not medical marijuana dispensaries. And in particular, tobacco shops may be a unique, unstudied nuisance property. And the reason I felt strongly that we could say this was we then also conducted ordinary least squares regression and something called GWR regression in ArcGIS, in which we were able to control for social disorganization factors and other social factors like poverty and race. And when we did that, tobacco shops were the only legal drug outlet type that independently associated with crime and violence in South LA. Now, the real reason I just wanted to tell this story and frame it in a community engaged research standpoint is we were able to publish this in Preventive Medicine in 2018, in January 2018. And the only reason we ended up pursuing this line of research was because we happened to stumble across it while doing these mapping sessions. The participants basically pointed us to tobacco shops, and then we conducted this study just to see if we could validate their concerns. But in January 2018, we published this, and I was not expecting the next steps to happen. But by March 2018, Coco, working with LA County Supervisor Mark Ridley Thomas and his office, then were able to create a motion for LA County, which they called Addressing Nuisance Tobacco Shops. And it starts, a 2017 study by UCR School of Medicine showed that South LA tobacco shops are associated with high levels of violent and property crimes. If you skip to the second paragraph, they said this study empirically supports the widespread concern from the community. So from the publication of this in January, by March, the community had really pushed this. And they actually pushed it to the degree that they came out and they testified. So right here, you see on the right side, that's Alberto Rotana. He's a president CEO of Coco. He's testifying. And they had other public health officials, other organizations from South LA testify in support of this motion. And then they, thankfully included me as the first speaker to talk about the study and what we found. And so from this, they have now passed successive motions to start regulating tobacco shops in LA County, which is a really nice thing for the community. When we scale back to the research aspects though, again, this is not something we were thinking about pursuing. I'm not a crime, violence, or at the time I wasn't a substance use researcher either. But the community pointed us to this issue. So we had a publication in 2018 I talked about, a subsequent in 2020. But then Dr. Grills and Coco were able to get a tobacco-related disease research program grant to scale up this little study that we had conducted. And now there's another follow-up TRDRP proposal in, and NCI R01 is going out with some members from USC IAS, I believe. So that is an example of what I think is ultimately ideal around community-engaged research, is that it can inform the science itself, but ultimately the concept is that you should be having some impact back into the communities in which they were gracious enough to honestly partner with you on. So what did we, I guess to sum up, community-engaged research methods can be used to shape substance use disparities research agendas, tailor evidence-based substance use interventions with vulnerable communities, and then develop these new research lines and studies to address substance-related disparities in these communities. Okay, and now I am out of breath. I'm losing my voice, so thank you all very much. I feel like I ran a gauntlet or a race. I don't know, I must have.
Oh, really?
No, not really.
And no disapproving eyes in the audience, just zoomed out. Yeah, that was great. Thank you, Andy. A really impressive and impactful line of research. And so folks in the audience, feel free to post questions in the chat or raise your hand. And so while the audience processes kind of and digests what you had presented, so yeah, I'll raise a question. I mean, that's pretty interesting, like the last part, right? You kind of just stumbled on to this research and really just, it's kind of like a public health and social, what do you call it? Like a social policy issue, right? And so, and I especially like that you had the opportunity to go, talk to the policymakers and really impact. That was really great. One of the things that I thought of is, tobacco shops. Tobacco is one of those substances. I mean, there are many substances like this, but particular tobacco, we're seeing increasingly more and more that it's so strongly associated with disadvantage. And any type of disadvantage we're seeing, like it could be economic, it could be medical disability, mental health issue, and of course, all sorts of racial and ethnic disparities. And so I don't know if you thought about that. I never thought like that there could be some sort of linkage between the shops and other outcomes. But I don't know if that occurred to you or you thought about this, because this is not something, a tobacco shop 40 years ago, we wouldn't see crime. It depends on the area, of course, they're in, but more higher income folks would be heading into those shops. So anyway, I just thought you might talk and riff a little bit about that, Andy.
Yeah, I mean, that was, I guess there's two things. I'll also say the next steps for this research are looking at things like vaping, because that's also something just like tobacco seems to be linked with disadvantage too, as far as populations. But, not every property has these challenges or will shape crime, or in this case now I think we've expanded to looking at things like asthma, how's it shaping use. That's the other grants that we've kind of pursued and gotten. But what's really interesting about it is the framing around the social disorganization is there has to be some other way of explaining why does a tobacco shop in Venice or a smoke shop in Beverly Hills, because you see them there too, why are they not, threatening the community health and triggering substance use the same way we suspect they are in South LA? And that's where we really start thinking about these social determinants, right? The same ones you were talking about, the structural disadvantage. And I think our evidence is starting to show when we look at things like that associate with social disadvantage, like renters. I haven't talked about. The more renters you have, the less these informal ties you get. That seems to be correlated with the proliferation of these nuisance properties in certain, more racial diversity, strangely enough, is associated with this disorganization in some communities. Yeah, so there's a lot of more social aspects you have to start considering when you start thinking about substance use disparities, at least, as opposed to the behaviors themselves. Yeah.
Yeah, that's really interesting.
Yeah, but yeah, I was just riffing. So
yeah, no, just
long story short, I don't know. Yeah.
I know, right? Yeah. Give this guy more funding so he could do more research on it. Save some for the rest of us. Another thing that I think is interesting is, you work on Filipino community and how you've partnered. You have like this group that you work with in Arkansas, right?
Hmm.
And then I know you've worked with Filipino communities here and elsewhere. What have you noticed about the differences geographically, but the common ethnicity and I mean, so what have you seen there?
Well, Charlie. Okay.
Yeah.
Yeah, I mean, that's a really interesting question, I guess. Well, so you actually stumbled across, I'll just say, a really interesting thing when you said Filipino, because Filipinos also are a unique group because we don't quite know if they're Asian American or Pacific Islander. And yet there are probably 3 times more Filipinos in the US than Native Hawaiian Pacific Islanders. So I'm actually writing a paper now to try and figure this out. So, but what we're finding basically is there's a lot more generalities. Even though there are over 20 different ethnic groups representing Pacific Islander peoples, from 3 different areas, Polynesia, Melanesia, and Micronesia. What's interesting is I thought we'd find a lot more differences between urban Samoans and rural North, Arkansas, and we're not finding much differences. They're pretty consistent. And this makes me actually feel really confident that we can create a generalizable intervention for everything that we're doing, whether it's Native Hawaiians in Hawaii or Tongans in Utah. Community and context matters, but the fundamentals of how culture is impacting substance use seems to be quite consistent. Yeah. And part of it might be rooted in like cultural trauma we were talking about earlier, right? This historical trauma, along with Filipinos. Yeah, who are the only group colonized by U.S. who are considered Asian Americans in the mainland U.S.
Yeah,
Hawaii Filipinos are not considered Asian, by the way. So it's very strange when I came here and saw them lumped in with Asian Americans. Yeah.
Oh, interesting.
Yeah. Context always matters, I guess.
It sure does.
Yeah.
And then you can see do you want me to read that question from Dr. Kaplan?
Yeah, no, I see it. Well, yeah, why don't you read it for the...
Sure. So do you have an explanation why medical cannabis compared to tobacco in liquor stores has no effect on crime in South LA?
Yes, good. I actually typically have a little section about why not medical marijuana dispensaries. So thanks for asking that, Charlie. But really, we did look at it. And what we found was that just by scanning these medical marijuana dispensaries, they have 3 things that tobacco shops and liquor stores didn't have. They had the presence of property safeguards. They had really a lack of advertising in South LA compared to places like Venice. In Venice, you can walk and you can see a big dispensary with a lot of logos. And I had pictures of medical marijuana dispensaries in South LA, and they're very hard to spot. They might have a tiny logo or they call themselves med centers. Mm-hmm. And then the third thing is they rapidly open and close. And I have a lot of pictures of like really well-known places like the Purple House in South LA in 2014 being really active and then completely shuttered 6 months later. So they're opening and closing so quickly that they can't seem to be like shaping the community locations in which they're at. So yeah, so those 3 things, safeguards, they're inconsistent, they move a lot, and then they don't really seem to advertise. very much their presence. Like liquor stores are the opposite. You know what a liquor store is in South LA.
Okay.
Yeah.
Well, wonderful. We could talk all day, but we appreciate your time and your energy and your effort and the beautiful presentation, and look forward to continuing to follow your work, Andy, and increase collaborations with more folks at USC. And I think we have some other folks on the call from other universities too. So he's great to collaborate with. So I'd recommend anyone on the call reach out to him. Before we wrap up, I'd like to make a plug for our future distinguished speaker series talks that are upcoming. You can see them on the screen, just quite a diversity of different areas that these people work in, but we want to also highlight a special event where we're going to have Dr. Rahul Gupta, who's the director of the National Drug Control Policy office within the White House, who will be doing a webinar. So that should be really, really interesting for him to kind of talk about, under the Biden administration, how they're approaching current issues that are really important and hot topics, including harm reduction. So with that, let me thank Dr. Subica again, and thank everybody for coming. I hope you have a wonderful day.